time. So we were talking about somatosensory pathways and how you feel things and respond to things. So we're going to go a little bit more into that topic, and then we are going to look at nerves. So we're going to look at cranial nerves and some spinal nerves and things that are interesting to know, and exactly which nerves you should focus on. Okay. So here, when you're looking at, we have seen this slide before, so I'll put here in a bit more details to make it more simplified. Okay. So when you are looking at information that is coming from the outside and is getting to your CNS, right? So you have to focus that this information is going to go through different levels. So the first level that you're going to look at is this receptor level. And remember, we had looked at all different types of receptors, right? You're going to feel all different types of things, right? So at the receptor level, you are going to start generating those graded potentials that are being felt by that particular receptor at one particular place, right? Remember, you're going to feel either pressure or heat or some other type of sensation, and you have to match your receptor to the stimulus that you are receiving. So you're going to gather all those graded potentials, and if you have enough stimuli, you are going to cause the action potential to fire, right? So you're gathering information at the receptor, then let's say you cause action potential to fire, right? Then this thing is going to go through a circuit that is going to is going to determine whether you're going to respond or not to that particular stimulus, okay? And this circuit is also going to tell you whether you feel or not something, where you're going to perceive that information. Sometimes you start feeling it, but then you decide not to feel it again. So then you can undergo a level of desensitization. So depending on the level of sensitization that you have, you're either going to feel or not that stimulus. Okay. So again here, what happens? First, you're going to start the graded potentials at the receptor, and that is going to send a signal that is going to go to your CNS, so that's afferent type of pathway, okay? Then you're going to interpret whether you are going to respond or not. So you're going to go through the thalamus. Remember, the thalamus is a very important decision filtering part in the brain, right? So then you're going to determine whether or not to respond. Okay. All right. So here are a couple also of review slide on the processing of information. Right. We know that in order for us to survive, we depend on whether or not we're making the right decision after we interpret the environmental signals, right? So the survival basically depends on whether you feel the stimuli and how you interpret it, okay? Have you heard of people that do not have nociceptors? Yeah, what are nociceptors? Pain receptors. So those people that are born without those nociceptors, what happens to them? They don't feel pain. Have you seen documentaries of some kids and the parents have no idea that the kids now have nociceptors? It is very scary. You know, at first I was thinking, oh, it would be nice not to feel pain. Yeah, but yeah, it's dangerous. There was this kid that was watching the documentary a few years ago, and at first the parents thought it was a bit unusual, and when they would take the baby for immunization shots, and the baby would not cry. So the nurse would just stick their leg, have you seen how the babies get the immunization shots? Like right on the leg, and like, oh, poor thing, I feel the pain for them, right? And the baby would not cry. And the nurse said, oh, what a happy baby, No, the baby did not have pain receptors. And then what happened to the baby? It was growing older, and then it got teeth. And then the baby started to eat solid food. But the baby did not know that the tongue was not a piece of the solid food, so they literally would chew their tongues out. Yeah. And I was watching this documentary with the father saying that he was feeding the baby, and all of a sudden a lot of blood started to come out. So the dad thought it was so the baby bit a piece of the lip or something. No, it was a piece of the tongue that fell out because the baby chewed right through it. Yeah, scary, right? And when you have that phenotype of no development of pain receptors, it also comes with another phenotype of developmental issues, central nervous system issues, so developmental delay issues. The child does not develop proper cognition or proper intellectual properties. So they really don't understand that it's dangerous, what something is dangerous compared to what is not dangerous. So the child can get into situations that they hurt themselves and they don't even know they're hurting themselves, right? Actually, those children, they actually have to have all their teeth taken out, or they can bite themselves. They have their nails taken out, or they can scratch themselves to death. It's a very, very sad situation, right? All right, so sensation of pain, and then the perception and the conscious interpretation of what to do with that sensation. We're going to look a little bit more into that now. So you're going to have 3 levels of integration of all of these signals, right? So the first level here is really at the receptor level, okay? So those are your sensory receptors. And then the second level is at this circuit level that is going to bring the information through ascending pathways, right? And then you're going to have here at the thalamus, you're going to have decision making, and whether or not these signals are going to be sent to the somatosensory cortex. Remember, that is after your central sulcus here, right? Somatosensory cortex, then you're going to perceive the signal and then decide on what to do, right? So here I had that slide showing a practical example of these levels of pathways, right? So this girl here is actually going to put her cowgirl boot on, and there was a spider on, like inside the boot. So she feels that there is a spider, right, in the boot, and then what does she do is like, ooh, my thalamus would definitely tell me that I should feel the presence of that spider. And here is when she sends the signal to the somatosensory cortex, and then she will decide, there are connections between somatosensory and the motor cortex that is right in front of it, and then she's going to send in a signal like, take your foot out of there, because the spider might, bite your foot, right? All right. So here at the levels of organization, right? So here you have your receptor levels, and receptors that are going from your skin or from muscles or from joints, right? Those are all part of your somatic type of input, right? Somatic input here. Those are receptor levels. So you're going to go and conduce it to the CNS, right? And here, after these afferent things get to the thalamus, right there, okay, you are going to decide on sending the signal to your somatosensory cortex. Remember, this is the gyrus that is after the central sulcus, so it's post-central gyrus, right? And here you're going to have those association neurons. They are going to connect with your motor cortex that is right in front, right over here. and this is part of your precentral gyrus. And then from the motor cortex, you are going to have cortico-spinal tracts. They are going to come down to your through the medulla here, right? Comes down to the medulla and goes to the spinal cord. And you're going to send the signal back through the motor neuron on how to respond. Okay. Remember that when your signal is coming down from the cortex through the pons medulla going to the spinal cord, you are going to have a space right here at the medulla in which those tracks are going to change the direction of the path. Whatever is on your right side of the brain goes to the left side of the body, and whatever is on the left side goes to the right side of the body. That point is what you call the decussation of the pyramids, and this is right here. Okay, so here at the medulla, you have the tracts that are coming from the cortex, and at this point they are going to cross over to the other side, and this is the decussation of the pyramids. That's the point right there. Contralateral coordination. Right there. All right, so here we have receptor levels, right? So let's see here what is important to know. We should know that when you are feeling the information, right, coming from the outside, you are going to have to detect the type of energy that you have the receptors for. Okay, so if you are going to feel pain, you must have the nociceptors. If you're going to feel heat, you also must have the proper receptors, right? So the energy of the input has to match the receptors that you have. Second thing that has to happen is that it has to be in the area that your receptor can feel, right? So if you have certain receptors in one area and not in other areas, and the stimulus is in an area where the receptor is not there, then you're not going to feel that area. Okay, now what am I talking about? The only example that I can give you that would make a lot of sense is, like, let's say that you have surgery for any reason. Okay, I say, well, in my case, I had several surgeries. You don't have to go through the whole thing, but let's say one time I went to have surgery for removal of excess skin, like from my legs. I actually took a huge pizza slice of legs out of, skin out of my legs, because I used to be like morbidly obese, and then I got rid of like 120 pounds or so, and then you had a lot of hanging skin. I had a lot of hanging skin. This is the next stage, and then I have to get it. Anyway, there's still improvements to be done. But then at that point, I took out this bunch of skin, and then with the skin came a lot of those sensory, parts, right? The sensory perceptors, whatever receptors that you had to feel something. And then the skin got together, like one part got together to another part. So I would touch one part, and I would think that I was touching another part. I was like, what on earth? And then I would touch that part, and I would feel like it's on the other side of my leg. And it took a long time for me to realize that my sensors had shifted space. Okay, so that was an interesting thing, yes.
Did your mind ever remap the connection?
Oh yes, I had to do this whole remapping thing, because there was one whole part of my leg that I wasn't feeling anything, but actually I was feeling, I just was not feeling that it was there. So it was kind of a confused state of mind. But your brain is very malleable, it will adjust. Yeah.
How long did that take?
Over 2 years. Yeah, it takes a long time for your brain to do the adjusting parts, right? But this is the kind of thing, you have to have the proper energy that is going to match the receptor, and then you have to be in this field where you can actually know what you are feeling, right? If you don't have a receptor there, you're not going to feel something over there, right? And then you also are going to determine what type of stimulus you're going to get out of this input. Because remember, when you're getting the information from the outside, you are generating those graded potentials here at your receptor, okay? So if you have enough of those graded potentials that are generated, then you are going to generate the action potential or not, right? But once you have enough of that energy that hits the axon hillock, then if you get the polarization of the axon hillock, that's when you're going to generate the action potential to send it to the CNS, okay? So now, we need to talk about two types of graded potentials, okay? So here, the first type of graded potential that you have is a simple type, and this is called generator potential. So this is when you have the dendrites of the neuron that are at the receptor site, and then those graded potentials are hitting the dendrite, are hitting this end of the neuron. And then if you have enough of those graded potentials here, okay, for example, here are sensory neurons, let's say, for example, for heat, okay, if you have enough depolarization, then you are going to cause the action potential to go through this dendrite and hit and be taken to the cell body, okay, be taken to the cell body. So this is a general type of receptor, okay? So here, this is what you call your generator type of potential. These are all graded potentials, and then once it hits a certain space that you accumulated enough generator potential, you're going to cause action potential, okay? The other type of graded potential that you have, it is called receptor potential. And this has to do with another cell that is going to be present and feeling the input before you activate the neuron, the sensory neuron that is going to take the information to the CNS. Okay, so receptor potentials are really important for special senses. Okay, so these will have to do with vision, smell, and taste mainly. Okay, so location of those are mainly for special senses. Okay. And here, what is going to happen? You're going to have this special cell that is going to detect the input, and then this cell is going to determine how much neurotransmitter is going to stimulate the graded potential of your sensory neuron that is after the receptor cell. Okay. All right. So here comes your first question. All right. So how does the strength of a sensory stimulus affect the generator potential in sensory neurons, sensory receptors, right? So now you have to think about the generator potential, okay? Let's see what you say. I have some people saying it's D. It's not D. There's always somebody who answers E. Okay, thank you. They changed their minds. They're going for E again. All right. Does anybody need more time? Yes. All right. Consult your friends. Right, you cast your answers? Wait. Oh, can we talk about it? All right, I'll give you another clue. On B, I should have said here, the strength of a stimulus is correlated with the strength of receptor action potential. So I should have put action potential over there to make it more clear. Okay, so now have you cast your votes? No, just do something. It's not D, it's not E, not A. Okay. It should be between two answers here. More people are giving me the correct answer. Yeah. All right, I'm going to stop it. Just take a chance. At least you get 1 point for participation. Worst case scenario. All right, so I'm going to stop it. What is your answer? C. Okay, let's see why. All right. Some people answer B. This is why I said I should put action potential right there. Okay. The strength of the stimulus is correlated with the strength of the receptor potential. This is the action potential. After you generate the action potential, then you're not talking more about graded potentials. Action potentials are all the same. Okay, this is why B is not correct. The correct answer here is C. The stronger stimuli will give you more generator potentials because those are your graded potentials. Once you gather enough graded potentials to cause action potential, then the action potential is all the same. Okay? Okay, so the other answers should be clear that they are wrong. Okay. All right, so let's look more at how this is taking place, right? In proper terms for when, okay, so somebody is like, not my fault. Okay. All right, so let's see here some more, okay? How this is taking place with this whole circuit business, right? So first thing that happens, you're going to stimulate your receptor, right? So the stimulation of the receptor is going to reach a certain threshold, and this is the same for everyone, right? You reach a certain threshold, and then you're going to cause that action potential to travel all the way to CNS. This traveling of the action potential here, okay? Okay, so first you start with the stimulation, then you're going to have whether or not you're going to activate your action potential. This whether or not you're going to activate the action potential is called transduction, okay? So when you get graded to action potential, this change from graded to action potential, you call that the transduction period, okay? Once you have your action potential, then you're going to travel all the way to your CNS, and this is the part that is going to be going to conduction. Okay, this gets to be a bit tricky on these terms. Okay, so you do the transduction, you get to your CNS, then you are going to conduct this to higher CNS centers. This is conduction to the CNS. Then you're going to have interpretation and translation of this signal that was received at the level of the cerebral cortex. Okay, so this is going to be a somatosensory interpretation at the cortex. All right, so let's see if this makes sense here. Stimulation, transduction that goes from here to action potential. So this is your action potential. And then you're going to have conduction to CNS. And then you're going to have transduction, you're going to have translation of your input. And I told you these terms, like, not my fault, okay? So I tend not to ask you on these specific questions on terms. I just want you to know what is happening at which stage, Okay, so the main idea of what's going on to me is more important than if you know the specific term, where is transduction, where is conduction. Because if I get confused, I imagine you're going to get confused too. So let's get to the part that I find is more interesting. Okay, this part here is interesting. So this is adaptation or interpretation of what you are feeling. Okay, look at this. The adaptation. This has to do with you changing the sensitivity of what you're feeling and interpreting whether that feeling is important or not. Okay, so you're going to have adaptation once you have a stimulus that is happening all the time. If you don't have adaptation, then the stimulus is going to drive you crazy. Okay, and this is in a case of, for example, when you are aware that, as I mentioned before, when you are aware that you are wearing socks. So you're going to adapt your CNS to ignore the signals that are coming from your socks. Otherwise, you cannot focus on anything else, right? Or some type of fabric of your clothes. There, yeah. Yes, this is one of the forms of adaptation. We have two forms of adaptation. Okay, so one, let's say for example that some people don't like to feel the cotton feeling of jeans, right? So if you put jeans, you're like, this is uncomfortable. This is uncomfortable. I gotta take it off, right? Yeah, I know. I go through this exercise like every day. I go put some clothes on. It's like, I don't like this feeling. I throw it out. I put it in the corner. I put something else like, okay, this is a little better, but not quite for the mood today. So I take it out. I put another one. It's like, all right, this one will hit the spot. So I have to have this whole 20 minutes of trying on pants and see which one is going to agree with the mood for the day. There is a reason for that. I'll tell you. Okay, so, all right. So this is a kind of adaptation. Say, okay, this feels good. All right, I can handle this. So I can focus on the lecture and not on how my jeans are feeling. Okay, adaptation for this constant stimulus, right? So what happens here is that your receptors, let's say like at the skin, they are going to become less responsive to the presence of that continuous stimulus, right? So we have two types of adaptation for those receptors. So one of them is called phasic adaptation. And this is a type of fast adaptation that we should all have, okay? So this is, for example, when we mention the clothes. So I put the clothes on, let's say, okay, I'm going to have a quick, fast adapting response, and I'm going to ignore my clothes afterwards, all right? Phasic for fast adapting response, all right? Another type of adaptation is called tonic, and that one is going to take longer for you to adapt. So this one is, for example, constant smell, right? And this is when we give the example of, let's say, somebody who knows a cat person, right? You know, like the crazy cat lady, you know? Yeah. So yeah, I have cats, I have dogs, you know. So in my house, although my pets are usually very clean, you're always going to smell some, you know, cat or dog around, right? So yeah, because they have their particular smells. I don't smell anything. I mean, you come to my house, some people have very sensitive sense of smell. It's like, oh, you have a dog? Oh yeah, I have a dog. She smells okay. She's clean. No, but yeah, she smells like a dog. Right? But after a while, after an hour or two, you are able to ignore the dog smell, right? My house doesn't smell bad. It just has a particular dog smell because yeah, I have a dog, right? Now, another example of this is also when you go to choose a perfume. Let's say you have a birthday party to go to, and you go buy a perfume for, you know, somebody. You go to a perfume store and you start to test the perfumes, right? The tester. So you smell the first one, it's like, I'm not sure if I like this one. Let me see another one. I smell another one, it's like, I think I like this better. And the third one's like, maybe I like the first one better. After half an hour or so, you can't smell anything anymore. Right? You just smell a bit of alcohol and that's it. It's like, oh, great. Now I don't know which perfume to take. And then you ask the salesperson, like, which one do you like? Right? And you don't get confused. So this is a type of tonic adaptation that takes a bit longer for you to start desensitizing your sensors, right? So everybody knows the difference between phasic and tonic. Yes? Because I always like to ask you questions about that. Okay. All right. And then we'll bring you to another topic here, that is perception of pain. So the phasic and tonic, that is really for perception of stimuli, and this kind of stimuli is painful stimuli, right? So now we're talking about pain. This has to do with how sensitive you are to pain stimulus, right? So there are some things here that are the same among everyone, and there are some things that are different, okay? How sensitive to pain you are. So pain tolerance. When you talk about tolerance, you're not talking about the stimuli that are needed for you to reach threshold and for the threshold to send action potential. That is the same for everyone who does not have problems of expression of nociceptors. Okay, so a normal, I would say, normal expression among everyone, those nociceptor problems are actually very, very rare. So everybody has about the same type of receptors. So let's say you have a threshold that you're going to start feeling the pain, and this is the same for everyone. Everyone is going to feel after a certain amount of pain. Now, this is the part that is different, the tolerance to the pain. So everybody feels the pain, but then how much of that pain can you handle? That's the part that is different among people, okay? And then I always have the question, is it true that women are more tolerant to pain than men? It depends. It depends on the culture, on your mental state, on hormones, on stress levels, on your mood, on your genes, not genes, like genes, okay? It depends, yeah. I don't know how to measure that. Yeah, 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 exactly. Exactly. How are you going to measure pain? You know, like when you go to the hospital and you have those charts on the wall, like how happy you are with your pain. I am not happy. Okay, and then it's like, okay, happy face, like, oh, that really hurts. It's like 1 to 10. It's like, huh? Yeah, so it's very, subjective. Okay. And one thing that also reminds me of this, tolerance to pain and whether or not people feel pain or not, is like one time I had to go for a biopsy, right? A cervical cells biopsy. And then the doctor, right, the GYN, tells me, oh, don't worry, it's not going to hurt because the cervix does not have pain receptors. How does he know that? Exactly. It hurt like hell. It hurt a lot, okay? And then I'm thinking, yeah, you are telling me that cervix does not have pain receptors because you are a man. And I had some bad thoughts in my head, but anyway, I'm not going to share those. Okay. He's like, okay, let me go like this. Oh, it didn't hurt. To me, it didn't. Okay, so tolerance to pain, right? Your level of hormones, stress hormones, how stressed you are. When you are stressed, some people feel more pain, other people feel less pain. Who knows? All right, so talking about pain, right? Different levels, different tolerance. So you're going to feel the pain at the same threshold, but then how much you can tolerate, that has to do with, a lot of things. All right. Now here, there is this other thing that is called referred pain, okay? Referred pain has to do with information that is coming from your gut, from your internal organs. So that is visceral pain, all right? So what happens here? When you have pain that is coming from your organs, remember this is felt at the somatosensory cortex, at specific areas that, of course, you do not have the corresponding areas at the motor cortex. So you can only feel those pains. But when you have the afferent nerves, those afferent nerves will get together with some other nerves that are coming from different areas, and they all travel together to a certain part of the brain, right, to the somatosensory cortex. And sometimes when those nerves are arriving together, your brain does not really know how to interpret where that pain is really coming from. Okay, so then what happens here? You have these fibers, those nerve fibers, they are traveling together, and then they are going to stimulate part of the brain. That one part has to do with the real origin of the pain, and another part has to do because of some nerves that get associated with the first nerve. So here, if you look at your sensory receptors for liver pain, they get together with a nerve that is coming from the somatosensory that has to do with your upper shoulder, with this part of the close to the neck. Okay, so sometimes you have pain over here and you think it's muscular, but it's really something wrong with your liver. So this is what you call the referred pain. Okay, and then in case of men, sometimes they have pain in their left arm, and that is not really pain in the arm, that has to do with a heart attack. Or also pain in the chest, that has to do, or in the neck, right, left side of the neck, that has to do with a heart attack, right? But you should really learn, like when you go to medical school or health professions, that this type of pain that is unusual, like unusual pain in the left arm and you are not exerting your arm, that is a sign of a heart attack, right? But then this is mainly for men, so this girl here is kind of misleading with the arm pain. For women, it's different. Do you know what is the referred pain for a heart attack in women? Lower back pain, not quite. Indigestion, stomach pain, abdominal pain. That is a telltale sign for heart attack for women. Okay? So you go to know, like, oh, I don't know, I didn't eat anything wrong, it's just like I got this indigestion. You should check the heart. Okay? And then look here. Sometimes you have, yeah, of course, if you feel abdominal pain in this quadrant, that is related to appendix. But this is like close enough to the appendix that is not such a weird spot. Okay. Now look at this one here. Gallbladder problem, like gallbladder stones. You feel pain in the shoulder. What does that have to do with the gallbladder, right? And sometimes doctors miss this referred pain, right? Thinking that, what is the pain in the shoulder? They don't even think about the gallbladder. But here's a little map of these referred pains. And the reason why you feel referred pain, right? Fibers traveling together. All right. So here we look at the structure of a nerve, because remember different fibers will get together on the nerve and then they'll travel together, right? So here it kind of looks like a structure of muscle, right? So you have here your axon that is myelinated, so these are peripheral, right? Most axons at the periphery are myelinated, right? So you have the axon, and then covering a single axon here, you're going to have the endoneurion, okay? So endoneurion is going to cover the individual axons, and then you put a lot of axons together, and you're going to have a fascicle. Okay, it's fascicle. Then what covers the fascicle is the perineurion. Okay, and when you put several fascicles together, also remember that a nerve is going to have blood vessels that travel also right inside the nerve. So put a lot of fascicles together, and then you're going to have this outer connective tissue covering, and that is your epineurion. Okay, and this is what is going to form your nerve. Okay, so different levels of connective tissue. Stuck. Okay, when you look at the nerve, it basically, when you say nerve fiber, that has to do with the whole thing there. Okay, so then you're going to have the type. Yeah, fiber is more specific for what is inside of the nerve. So you're going to have, most of the time, for example, all the nerves that are coming from your spine, they're going to be mixed. So they're going to have fibers that are going afferent and then fibers that are going efferent. Okay. But then with other types of nerves, mainly cranial nerves, you're going to have some fibers that are only sensory, and then other fibers that are only or mainly motor, or some mixed as well. Okay, so let's see here what is important to know about those nerves. All right. So first thing that I want to mention here is when you look at peripheral nerves. Okay, so let's say something happened and you had a cut on an axon of a peripheral nerve. So what is going to happen here? Peripheral nerve axons, most of the time, they can regenerate, but it takes a long time. And it also depends on whether the associated cells got damaged or not. Okay, so let's say here, for example, that you had some damage to the axon, and the surrounding cells were not damaged. So those Schwann cells are actually very, very important not to be damaged around the damaged site. Okay, so what is going to happen here? You're going to have degeneration of that nerve. Okay, so here is your nerve that got damaged. You're going to have degeneration going down from the damaged site, or going more lateral from your damaged site. So from damage all the way down, that nerve, that neuron is going, neuron axon is going to be degraded. Okay, so here you're going to have pieces of fragmented axons, okay, that are going to be degenerating. The name that you give for the piece that gets degenerated, that gets degraded from the injury site downwards, you call that Wallerian degeneration, which is down right here. Okay, so all these pieces are going to be degenerated. Then what is going to happen? You're going to have your Schwann cells that are going to jump into action for cleaning up the debris of the axon that got degenerated. Okay, so these Schwann cells, they are going to call on macrophages. They are going to get to the site and clean up all these debris, all the debris that is present there. Okay, macrophages are part of the immune system. Okay, so then macrophages are cleaning up, and then after you have all the cleanup, they are cleaned up, the Schwann cells, they are going to start to create that myelin sheath again. So they are going to release growth factors that are going to start growing this axon from the part of the axon that was not damaged. Okay, so the Schwann cells are going to release these growth factors, and they're going to start creating here this axon, and this is what you call this regenerating tube. Okay, and the Schwann cells are going to round up, going to go around to insulate that that axon again, and you're going to get this this axon regenerated. Okay, so it takes a long time for that to happen. It takes I don't know, about a year or maybe longer. But then after you get axon degeneration, you're going to have to retrain your peripheral neuron on how to respond to signals. So a lot of times you have to undergo physical therapy and a lot of adaptation. Okay. Now, this is showing, okay, after you have the regeneration of the axon, and then the Schwann cells are going to envelop that axon and work properly. All right. That only happens to peripheral neurons. It does not happen to central nervous system axons. When you have damage of CNS axon, that is a permanent damage. You cannot go back and rebuild that axon. Okay? Why is that the case? Look at this. The fibers at the CNS, they're not going to regenerate. Okay? Remember that you also have myelination at the CNS, but you do not have the Schwann cells. You have those other cells with many arms. Those are your oligodendrocytes. Okay? The oligodendrocytes, they do not have those growth proteins, the growth hormone proteins that are produced by the Schwann cells. What they have instead is growth inhibiting proteins, okay? So that really prevents the regeneration of damaged axon in the brain. Okay, so whenever you have a major axon that is broken in the brain, that's usually permanent. Okay? What happens at the space where you have the damage usually form connective tissue or scar tissue that fills up the area that got damaged. Okay. All right. All right, so here putting more things together based on what we already have learned before, right? When you're talking about ganglia, you're talking about cell bodies that are in the peripheral nervous system, okay? When you are, again, referring to ganglia, those are going to be part of neurons that are afferent, so they're coming from periphery, going to the brain. And for example, here you have, in the spinal cord, you have what you call dorsal root ganglia, okay? So dorsal is more towards the back, right? To the back, like okay, dorsal part of anatomy localization that we've seen before, okay? So basically those are going to be afferent types of neurons, okay? If you have ganglia that are associated with efferent, those are going to be to the front or visceral part of the spinal cord. Okay, so let's see here. All right, so interesting things that you have to know about other specific nerves. Okay, so here you have, for example, your cranial nerves. No, you do not have to memorize all the 12 cranial nerves. You have to know that there are 12. Okay, but no, do not think about memorizing all of them, all the functions, but some of them you should know. Okay, first thing, you are going to name them in Roman numerals. Okay, and here some of those cranial nerves that I think are important for you to know, like cranial nerve number 1, that is your olfactory cranial nerve. And this thing is just for feeling smells. So it's purely sensory type of nerve. Okay. How you can remember this? You have one nose, so this is cranial nerve 1. Okay. Another one that is interesting here and is also purely sensory nerve is cranial nerve number 2. That is for vision. That's your optic nerve. Cranial nerve number 2. And yeah, you have 2 eyes, cranial number 2. All right. You have other nerves that are important for eye movement, but we're not going to get into that. Okay, so 2 for sensory for the eyes. All right. And then you have this other one over here. Look, number 5. This is an important one. This is your trigeminal nerve. This is a mixed nerve. You have both sensory and motor neuron. And where are you going to find this? This is cranial, so you're going to find it in the head. This one here is especially going to different places in the face. Okay? So you're going to have feeling sensations in the face, then it's also going to innervate the muscles for chewing, okay, in the face. So I have pictures for that. Okay, besides those, you should definitely know cranial nerve number 10, right? That is your vagus nerve. It's the only nerve that is going to come out of the head and go to the rest of the body. It's very, very important for parasympathetic fibers, okay? You're going to innervate the thorax and it's going to innervate all of the abdominal gut stuff. Okay, so that is your vagus nerve. Besides of that, you're also going to control voice, okay, and gag reflexes, right? So vagus nerve, very, very important. Okay. All right, so let's look a bit more on those nerves that you should know. So number 1, that is your olfactory nerve. Where is it that you're going to find it? Okay, so here. you are going to have, remember this bone over here, your ethmoid bone that has that cribriform plate? Yeah. So here you're going to have olfactory nerve number 1, okay, end of those nerves over here, and it's going to get together at this olfactory tract, okay, and this is actually called olfactory bulb that goes to olfactory tract, and it's like right there in the brain, okay. Brain. So one thing about this nerve, it is it's purely for sensory. It's for feeling, for knowing different smells. And here is your optic nerve, your cranial nerve 2. So remember the nerves, they always come in pairs, right? So here optic nerve 2, here cranial nerve 2. So here you are going to see this nerve right here, okay? And this cranial nerve is interesting because you're going to have a part of axons. They are coming from one eye and from the other eye, and they are going to get together and go to a certain nucleus in the brain, okay? And same thing with the other side of this nerve. What happens here, you see, they say they partially cross over, partially because one of them stays on the same side and the other one is coming from the other eye. So they partially cross over at this center point here, and you call that central point the optic chiasm, okay, right here. The part where your optic nerves partially cross over to the other side, okay? Then what happens here, these tracts, they are going to go to the thalamus, and then your thalamus is going to differentiate whether you're going to pay attention to something or not, okay? After they travel to the thalamus, they are going to continue to your occipital lobe, specifically here to the visual cortex of your occipital lobe. Okay, so occipital lobe in the back of the head, this is where you're going to interpret the vision. Okay, so optic nerve, cranial nerve number 2, is going to partially converge at the chiasma, go through the thalamus, and then get sent to the occipital cortex. And here comes your nerves 5, cranial number 5. That's called your trigeminal nerve, right? Trigeminal because it's gonna control different things, like 3 different areas in the face, okay? And they all get together at one point here, so they're really like converging at all these from all these different areas to one point over there, okay? So you're gonna have ophthalmic type of innervation, also maxillary and mandibular, okay? They get to the trigeminal ganglia. All right, so you can read that. I want to mention something that is very interesting about your trigeminal nerve. Anybody heard of the herpes simplex virus? Yeah, 1 and 2, yeah. Type 1 is very, very common. About 80 to 95% of the population has herpes simplex 1. Yeah, then, yeah. What does that cause? Cold sores. Yeah. So then what happens here? Herpes simplex 1 is going to affect the top part from the waist. Herpes simplex 2, not, thank goodness, not a lot of people have herpes simplex 2. That's mainly sexually transmitted, so it's kind of more difficult to get, okay? What is going to happen? Those viruses, they are going to affect and infect sensory neurons, okay? So let's see how that happens over here. So you're going to have infection of a sensory neuron. The virus is going to travel through the axon, is going to get to the cell body, and the virus is going to penetrate the nucleus, okay, the DNA of the virus, and is going to be incorporated into your DNA. So when are you going to get rid of the virus? Never. Once you're infected, that's it. You're infected for life. Okay. So look at this. Most of the time, herpes simplex 1 is going to come through endings close to your mouth or your nose. It's going to travel through this trigeminal ganglia, and it's going to be in the cell bodies over there, and it's going to stay there like forever. Let's not get into the other part here that is herpes simplex 2. Let's focus on the 1, okay, herpes simplex 1. So let's see what happens here. You are going to have those DNAs of the virus in your cell DNA like forever, and then sometimes, let's say that you get stressed out, or you're out in the sun for too long, right? And then you reactivate the virus. So the virus is going to travel down, is going to express, is going to get encapsulated, it's going to travel down, is going to come out here of your axon terminals, and is going to start causing you a cold sore again. Okay? Is it unusual that under stress you get cold sores? No, this is what is happening. Okay? So that trigeminal nerve is a nerve that gets affected by HSV1. Okay? All right. Oh, okay, so here's another question. Which cranial nerve is purely sensory and allows you to smell? All right, everybody has to have this one right. Okay, 5 more seconds. Okay, does anyone need more time? No? Good? Okay, so what is your answer? A. Yeah, that is your number 1. You got one nose. Okay. All right, so here's another nerve that is quite interesting. Your cranial nerve number 8. That is your vestibulocochlear nerves. Okay. Now look at this. You're going to get information that is coming from your inner ear. Okay, that's the cochlea. That's the vestibule, the semicircular canals. Okay, so here you're going to get information, and you're going to transmit that straight to this area that is right under the pons. So it's the medulla oblongata and the pons. So this nerve goes straight over there. Okay. What that information is going to tell you is about balance and also audition, right? But it's going to tell you how you can maintain your balance, and you have a notion of this proprioceptor information. Okay, so this is very important for balance. Okay. And here is your vagus nerve. Okay, very, very important vagus nerve. Again here, number 10, and it's the only one that is going to come out of this area and pass the neck and go down to the rest of the body. And look at all the organs that the vagus is innervating. Okay, you got here the lungs, the heart, the kidneys, the liver, stomach, intestines. Everything has some vagus nerve endings that go to them. Very, very important for parasympathetic action. So parasympathetic is your rest and digest state, right? Sympathetic is your fight or flight. So parasympathetic is rest and digest. Okay, so let me see here. Okay. So with the nerve, you also have, you not only have sensory, but you also have mainly sensory feelings of those organs. Okay. All right, so here is just putting in written form what I have just mentioned. So here's a position where you're going to find those nerves. So this is looking at the brain from underneath. So here you find your cerebellum. Okay. So looking from under, you're going to find here your olfactory bulb, right? Olfactory tract. So these are your olfactory nerve, and this is cranial nerve number 1. Okay. And here you're going to find the ends here of your optic nerve. This is number 2. This is your optic chiasma, right? And here you're going to have your optic tract. Okay. And origin of your trigeminal nerve. Okay, so remember they're always coming in pair. And here you're going to find your origin of your vagus nerve. Okay. Also, the nerve number 8, vestibular cochlear, is right there. So you should know, once you look at the bottom of the brain, you should be able to identify which nerves are going where. All right. And another question. Lots of questions today. Which cranial nerve is the exception and travels to the thoracic and abdominal cavities? All right. You don't need more than like 5 seconds to answer that. I give you 30 seconds. Okay, 5 seconds. Okay, what is your answer? That's your vagus nerve. That's your, come on, D. Okay. All right. So a little bit on the spinal nerves, not much, okay? Those are painful, right? So 31 pairs of spinal nerves. All of them are mixed, okay? All of your spinal nerves are mixed. All right. What are these nerves are going to supply? Everything in the body except for the head and some of the neck. Okay, so everything from the neck down is a spinal nerve. So let's see here what is going to happen with the connection of those nerves. Okay, so it is going to connect to the spinal cord, and you're going to have 2 roots. Okay, you're going to have the ventral root, and you're going to have the dorsal roots. So here, when you look at the dorsal roots, so this is close to the back, right? Dorsal roots, you're going to have mainly sensory input of those nerves. And then when you look at the ventral root over here, dorsal root over here, okay? At the ventral root, you're going to have mainly motor or efferent fibers, okay? So here is your spinal cord. Remember, your spinal cord, you have white matter on the outside, and you're going to have your gray matter on the inside. How do you know which side is dorsal, which side is ventral? The dorsal part, okay, here, dorsal root is right here. How are you going to distinguish that? Which one is the front and which one is the back? If you look at the vertebral column, at the bone, look here, it's going to be closest to the ventral. So your ventral root is going to be here, and then the dorsal root is going to be more to the other side. Okay, hopefully that will make sense here. All right. So the parts that are diverging from the nerve, you call that ramus. So this is like diverging, getting inside of your spinal column. I mean, vertebral column. You know what I mean. I'm getting tired. All right. Okay, so here, when you look at the nerves, they are coming from the lumbar vertebra and going also to the sacral you're only going to see the nerves, but not your, my brain went blank now, spinal cord. Okay, your spinal cord is going to end before your lumbar nerves start. So your spinal cord is going to come all the way to here before your lumbar vertebral column bones. Okay, so after that you're going to see only these nerves. They're going to come down and come out of the vertebral column space. But when you have only the nerves and you do not have your why am I blanking out on this name again? What is the name of the thing? Spinal cord, right? When you do not have a spinal cord and you only have the nerves, you call that a cauda equina. That means is the hair of the tail of the horse. Yeah, only hair, okay? Not spinal cord. Spinal cord is going to end up around here, okay? So that was the one important part that we should know here. Okay. Plexus, I'm not going to cover that. Okay, just one interesting thing here about your lumbar nerves that are coming out and innervating the leg. You have some very, very large nerves that are passing through that lumbar area between your spines, right, between the bones, and they're innervating your leg, okay? Now, sometimes with older age, you get degeneration of that disc. Remember, the disc gets to shrink. Then when you press on those nerves, a lot of times you're going to feel the pain that shoots down the leg. That's what you call the sciatica pain, okay? So those nerves are usually coming from lumbar bones, L1 to L4, okay? So you have L1 to L4. Those are the nerves that usually cause sciatic pain. They go to the thigh, to the leg, and some part of lower abdomen. So let me see if anything else I need to cover here. Yeah, this is exactly what I mentioned here about the sciatic nerve. They're really the longest and the thickest nerve of the body. Okay, sciatic right here. Huge, huge nerve. All right, so this part is important, right? So I really like to ask questions about these dermatomes. So these are parts of the body that are felt by certain specific nerves, okay? So a lot of times you can check whether the nerve has a damage or not by trying to cause sensation at certain parts of the body. For example, if you want to find whether somebody has damage at the level of the spine that is L5, so you touch the side of the leg. If the person feels the side of the leg, so you say, okay, so sensory nerve at L5 is not damaged. Then you go, let's say sacral 1. If you touch the side of the foot and you say person doesn't feel anything, so say, oh, so you have damage at that level of the column. Okay, so this is basically different areas of the body that receive sensation that get transmitted to those spinal nerves. That's called the dermatome. Okay. Okay. All right. So here a little bit about reflex arc. Okay. So arches. Some of them you have at the time that you are born, so you call those intrinsic reflexes. So those are really fast and involuntary, so you're not thinking about that, okay? And then some other reflexes you learn as you get older. For example, reflexes of certain skills that you have, for example, driving, right? So when you're driving, a lot of times you're not thinking about driving. You're just acting out of reflex. Or if somebody comes with a car too close to you, sometimes you have this jerking reflex or just trying to get away. You were not born with that reflex. You learn after you started driving. Okay, so this is result of practice or repetition, and this can also be included in sports. So you practice a lot of times certain skills in sports, then you start doing out of reflex and not really thinking too much about it. A bad thing about it is that if you have a bad reflex, to correct it after you learn it in the wrong way, that's a bit more difficult. But anyway, different thing. All right. So here, when you're talking about somatic reflexes, those have to do with skeletal muscles, right? And on the other side, if you talk about autonomic reflexes, those have to be with gut type of reflexes. So somatic is muscle reflex, and autonomic is for a gut reflex. Could also have to do with cardiac muscles as well. All right, here. So reflex path. What's going to happen here? You're going to feel a sensation is going to travel to your spinal cord. In the spinal cord, you're going to have interpreting neurons at the gray matter. And those neurons, depending on the impulse that it received, information it received, that is going to decide whether to activate a motor neuron or not. So this decision making is happening at the CNS, but inside of your spinal cord, even before you get the sensation of something that happened, right? So a classical example of this is when you touch a hot plate. A lot of times your hand is going to go away from the hot plate before your brain interprets that the thing was hot, right? So this is a reflex that is inborn and is a type of arch reflex that has to do with a motor neuron. Okay, so what is happening here? You have a receptor, you have a sensory neuron, you have integration center at the gray area in your spinal cord. Okay, then you're going to have a synapse with a motor neuron that is going to take it to the effector, that is your muscle. Okay, so this is going to be your effector. Motor neuron is going to, motor neuron, they're going to go to the effector and make the thing respond. All right, so very simple path of reflex arc. All right. So here, this is from your book, and this is the last thing I'm going to mention here. Okay, so first thing, you're going to have to detect the stimulus. Then you're going to bring it to the CNS. And this is not very accurate because this is going to the brain, but no, this goes to the spinal cord. Okay, so this is an error in your book. Okay, it goes to the spinal cord. This does not go to the brain. Okay, you're going to integrate the neurons at the CNS and the spinal cord, and then goes to motor neuron and effector response. All right. Okay, before you run out, last point for the class. Which of the following is the first step in a reflex arc? Okay, give you 5 more seconds. Get your points. Okay, what is your answer? C, you have to detect it.